Okay. So, as I said, I'm using a presentation that I often use actually for schools and things because I've had a bit of IT problems, so apologies. But I always think it's a good one to start with is this slide that says, why a speech and language therapist? Because people sometimes certainly raise an eyebrow when I say I'm coming to assess their child's eating and drinking. And it's basically because, as a speech therapist, part of our training includes the neurology, anatomy, and physiology.
Sorry, Nicole,
And
sorry to
oh,
interrupt.
yes, hello.
Just
My
have a question. Are you able to just pop it into presentation mode just so it's a bit bigger for everybody to see?
yes, sorry. Let me see where is slideshow. Is that the one
Yeah,
from the beginning? Okay,
perfect.
so we'll just.
Thank you so much. Sorry, I'll
Oh,
stop interrupting you now.
that's quite all right. No, please do interrupt because as you've probably gathered, IT is not my strong point. So that's me, basically, speech and language therapist, and this is the mechanics of eating and drinking. And as I say, we're going to start with this slide here, and it's basically as a speech therapist, as I say, we do the anatomy and neurology and the physiology, which is the function of everything to do with the head and neck. We also touch a bit on psychology, and there's a huge amount of that is integral to eating and drinking. So, if ever you're querying, or why is a speech and language therapist doing this, it's because we have this as part of our training. Many, many years ago, decades ago, in fact, I think the medical teams were aware that more feeding, eating, drinking, swallowing difficulties were being highlighted by nurses and other doctors and things, and they perhaps couldn't cope with all the referrals. So they felt, well, who is best placed to manage this with a knowledge of the neuroanatomy? And they thought speech and language therapists. So here we are. So moving on, what is our role? Well, it is to assess for dysphagia. And you may or may not have come across that term yet, dysphagia with the G. And I always think to differentiate it between dysphagia and dysphasia with an S, think of the gulp that you might do if you swallow a big gulp of water. That's got the G in it. And it's a dysphagia is when there is a swallowing, eating, chewing, or drinking or swallowing difficulty, as opposed to a sensory behavioural feeding difficulty where it's more a fussiness or a refusal or a reluctance to eat or drink. So we certainly work with both. We advise and provide recommendations on any modifications that might be needed. And we obviously provide some therapy to hopefully progress and improve eating and drinking skills, as well as any training to parents and other professionals. So, what is a normal swallow? I think it's important for us to sort of have an awareness of how often and what we do when we swallow. And put simply, we all swallow something pretty much every few minutes because you're managing your saliva. So we swallow roughly 1 to 2 liters per day, which I know can be a little bit perhaps nauseating to think of. So it's an awful lot of swallows a day. Now it's very, very common for babies, young children to drool. But on average, they are swallowing some of their saliva. For little ones with trisomy 21 or Down syndrome, they can have a more open mouth posture. And regardless of whether a child has that diagnosis, if they've got their mouth open and they're leaning forward with play or because of their posture or whatever, they may well be drooling more. If that's your child that you've noticed that they're really drooling a lot, just be mindful that they may well then be losing a little bit of hydration. And if it's becoming a bit of a problem, then speak to your GP. I know of one specialist clinic in London, which is at the Evelina, that is specifically for saliva management. But I'm sure there are others around the country, but they're perhaps not be that many, but certainly pediatricians would know how best to manage it. But again, back to the normal swallow, how does it work? Well, basically, when you've put some food in your mouth, we chew, otherwise known as mastication. We move it around our mouth using the tongue. And then as we push it towards the back of the mouth, that is the swallow triggered to then push it down into the esophagus or food pipe to the stomach. However, the other tube that we've got there, so Mother Nature has sort of like worked her magic, but it's not that always that clear, is that there's also the trachea or the airway, and that leads to the lungs. And you've all heard the expression when you're coughing and spluttering on your fish and chips or a cup of tea or something, oh dear, it's gone down the wrong way. Well, it literally has, and the risk is that that leads to the lungs and could end up with a chest infection. So this diagram, I hope, shows that a little bit more clearly. So I'm hoping you can see my cursor. And this is literally the head and neck, you know, in side section. And as you can see, the tongue takes up quite a big area. Then we've got the soft palate, and the hard palate, which leads to the soft palate. And then you've got these two tubes. So the one at the back is the esophagus, leading down into the stomach, and the one at the front is the trachea or windpipe that leads to the lungs. So again, it's just to sort of show you that once that food is pushed to the back of the throat around here, it's quite easy for it to slip down the wrong way. So when we're talking again about the normal or typical eating and drinking, the mechanics of eating and drinking, there are 4 stages that we generally identify. The first one being the pre-oral stage or anticipatory slit stage, and that's when you're showing or looking at your food and drink. So if your baby or young person is looking at the food and drink, that automatically signals them that they know food is approaching, which then gets them ready for the second stage or the oral stage, for them to be ready to open their mouth, take the food off the spoon or from their fingers, and then use their tongue to move the food to the biting surfaces for chewing, and then pushing it to the back of the throat, ready for the swallow. Then we've got the third stage or pharyngeal stage, which is literally where the swallow is triggered. And once it's started, you literally can't stop it. So if you've got a cup of tea with you now or anything stronger, take a sip and see if you can start that swallow and then stop it. You really won't be able to, or it certainly might make you cough and splutter. And this stage is very, very highly coordinated, and in certain, certainly in sync, certain structures have to move quite rapidly and in a coordinated way to ensure the food goes down the right way. And what's really important to remember at this stage is that in the throat, in order to protect the airway, the vocal folds, which are in your voice box, literally at the sort of Adam's apple area of your neck, they slam shut to ensure that food and drink should not go down into the airway. And so every time we swallow, whether that's your saliva, a cup of tea, a glass of wine, your fish and chips, we stop breathing, or even if it's your saliva. So when we see little ones eating and drinking really, really quickly, they might get a bit out of breath, but that means also that that coordination might get a little bit out of sync and they might cough. So once hopefully things have gone down or heading in the right direction into the esophagus, we've got the oesophageal stage, which means peristalsis is happening, and that's the squeezing of various muscles that pushes the food down into the stomach. So as I said, I want to sort of emphasize that there are 2 ways. So the right way, mouth, esophagus, into the stomach, but occasionally we have got things going down the wrong way. And the risk there is that an aspiration has happened, which means that the food or drink has gone below the level of the vocal folds, i.e. the Adam's apple area of the neck. And that's going to end up in the lungs and could possibly lead to a chest infection. So again, another diagram really just to sort of highlight the close proximity, which is why we just want to be mindful, especially with our little ones with Down syndrome, because they might have a little bit, finding it a little bit more tricky to coordinate that swallow. So at this stage, sometimes if I'm doing this face to face, I might get you to eat and drink something. And all I would say is, could you try, maybe after this presentation, have a think about what you need to do to manage different textures. So I've got here on this list meringues, Rice Krispies, Cheerios, or chocolate. They're all quite slightly different textures. So have a think about what you might need to do to manage those safely, as well as maybe something to drink. So the reasons for dysphagia, why does it happen? And I think it's important to emphasize that not every child with a special educational need has a dysphagia or even aspirates. But what we do know is that some children with SEN do have an increased risk of dysphagia, and that risk is actually higher for children with Down syndrome. And again, it's partly to do with coordination. It's also to do with muscle tone. They may find it quite difficult to break down the food. Their tongue might not be moving quite as efficiently or effectively in order to move the food around in their mouth to swallow it safely. And so the things that might cause this is, as I say, the low tone, but also oromotor coordination difficulties, cardiac issues, which we know can be really quite a high incidence with our little ones with Down syndrome. That just affects their stamina, if nothing else. So again, if you think about you're having to stop breathing every time you swallow, that might make this actual feeding and the swallowing quite hard going. So we just may need to pace things a bit more slowly. We might, with the weanings side of things, have to just take things a little bit more slowly before moving them on with textures. And what we do know is that quite a few children with additional needs often have sensory aspects going on. So they may be a bit fussier than some other children, or that fussiness might continue for a bit longer. So this slide is showing a still image, excuse me, from a video fluoroscopy swallow assessment, otherwise known as VF. And this is literally showing something where there is very much a dysphagia and an aspiration occurring. I appreciate that it's quite small. You may have had an experience of having to take your child for a video fluoroscopy, or you're perhaps waiting for one. And this is sort of the image that they would be looking at. So as you can see from the middle of the picture, I'm hoping you can see a very, very dark outline. And that's because this person has obviously been given, I'm assuming it's a bit of a drink. It might have been some yogurt, something like that, that's been mixed with barium. And barium shows up on an X-ray as very, very dark, very black. And so we can see very clearly where that food or drink is going. You can see to the right some horizontal lines. That's the vertebrae of the neck. And then in front of it are these two tubes. So the front one is the trachea or airway, and the back one that's a bit squiggly, that's the esophagus. And that's got most of this food or drink in it. But as you can see, the trachea has also got a trace which demonstrates that an aspiration event has occurred. On my usual presentation that I use for pads are some of these presentations from YouTube and other places. I'm not going to look at them now because we really don't have much time, but I would recommend that you have a look if you're intrigued or interested to know what a normal swallow may look like. There's also a very, very good one, the fourth one down, I think it's called Singing in the MRI, and it's an amazing chap who has been filmed literally doing various different vocal techniques. And the reason I sort of got it on here is because it's got a really clear, it shows very clearly rather how he uses his tongue and his soft palate and other things that you can then, you know, think about what happens when we swallow. So what are the signs of possible dysphagia? And this can happen literally from any age. So as very young babies, they can have all of these things, toddlers, right into high school and beyond. And even any one of us may develop a dysphagia into adulthood with just age-related changes. But the key things, the more overt signs, so the very obvious signs of something going a little bit wrong with the swallow, is coughing, gagging, extreme gagging, leading to coughing and possible choking during or soon after eating and drinking. Maybe a change, a wet, sort of gurgly voice quality, and even sort of wet or gurgly breathing. Eye tearing or eye watering as they're taking something to eat or drink. Maybe they might start to look a little bit pale, but equally they might start to look a little bit flushed, maybe start looking a bit sweaty. And that's just showing signs that they're maybe struggling a little bit with their swallow. The breathing rate might increase, but equally it might slow down a little bit too much. Shuddering, nostril flaring, as they're taking food off the spoon and actually swallowing. And then things that perhaps are not happening right at the moment of the meal time or the actual food or drink swallowing, things like that their weight gain has really slowed down or even become quite static. Maybe they've had a chest infection that's needed antibiotics, and then a few months later they get another one, and then a few months later they get another one. So it's these repeat chest infections can be a bit of a red flag that maybe something is occurring during the eating and drinking process, and it's not as overt during the mealtime, but something is going down the wrong way, but it might well be silent aspiration. So another red flag would be maybe frequent temperature spikes. So they get a bit of a temperature, they feel hot, you think, oh dear, give a bit of Calpol, it goes down, and then a few days or maybe a week or so later, they get another temperature spike. And that's perhaps suggesting that they're trying to fight off an infection. So if you just get one or two of these things happening, either seek advice from your GP, your health visitor, school nurse, depending on their age, and maybe ask for a referral to a speech and language therapist. But what to do if it's going wrong? So if you're at home and you've never actually had an assessment yet by a speech and language therapist, but you think, oh goodness, they seem to cough and splutter a lot on their food or drink or a particular type of food, then the really key thing is pacing. So it's slowing everything down, smaller portions as well. So smaller amount on the spoon or fork, pausing in between each mouthful to give them time to be able to clear, move the food to the back of the throat and swallow. Fluids in particular move much, much more quickly. So if you think of, say, a plate of water versus a plate of really thick custard, that custard will move if you were to sort of walk across the room with it, but it's going to move in a very sort of cohesive manner. It's going to keep its form, and it's going to move very slowly, versus that plate of water, it's going to slosh around and you'll probably lose a bit. So when we're drinking, if you think about the fluid going in, tipping back to the back of the throat, there's more risk of that going down the wrong way. So we often suggest thickening fluids. For very little ones, babies, we usually use cow and gate Carabel, which you can actually buy over the counter at your local pharmacy, and even some supermarkets stock it. You might have to request that they get it in, particularly in a pharmacy. But if you are seeing a speech and language therapist, then they can request a prescription via your GP. The type of thickener would change depending on the age. As I said, Carabel thickener is prescribed for babies, even preemie babies. But equally, if you don't have any thickener, specific thickener, you could thicken a liquid by offering, say, naturally thick fluids such as a smoothie. So bananas in other fruits all mixed together, blended really, really smoothly, that really can thicken it up quite a bit. The other thing is texture modification. So it's sort of identifying when they're eating and drinking. If you sort of notice, oh, they seem to do it more if, say, you give them, I'm just trying to think, say a rice cake or a breadstick or something, then maybe avoid those for a short time, and see if that helps. Maybe they just need a bit of practice a bit later on in a few weeks or months' time, or they maybe need something a bit more moist to go with it. So using dips and sauces, that sort of thing, to moisten a food and maybe soften it a bit more might help them manage it more safely. Positioning is really, really key. So we generally want, especially if we're sort of thinking for the weaning stage. So I'm not talking about breastfeeding or bottle feeding specifically at this time. But for solids, we want them sitting quite upright and really well supported. So have a think about the chair that they're sitting in. Has it got sufficient support? If it hasn't, and I saw a gorgeous little one today actually, who also happened to have Down syndrome, and his high chair was a bit too big. So we just rolled up some towels, wedged him in, because we want them to not have to think about supporting themselves in a high chair. We want them to feel supported and wedged in, preferably with a footrest, because again, that helps them to feel a bit more stable. Now, NBM, that's nil by mouth. So very, very occasionally, if we really are worried that they have had repeat chest infections, that they're just not managing food and drink, we may suggest tube feeding. They may have started with tube feeding when they were first born, and then the tubes come out, but then it has to go back in again. And it really is, it's a really difficult decision. We really don't want to have to suggest it, but it can really help them to regain strength, get better, and then the aim would always be to at some stage reintroduce solids or liquids orally and hopefully wean them off that tube in time. Again, the key thing is that they are seen by a speech and language therapist with experience of dysphagia, and as well as, particularly if they're getting a tube or if there's a concern about their weight, that the dietitians are involved. So again, this is when I normally do something far face to face, and I would be getting you to do various different things with food and drink. And I think if nothing else, it's just worth thinking about what it's like being fed. So if you've got a friend or a partner with you at some stage over the coming days or weeks, have a go at feeding them how you do your baby or your young child, and see what it's like, because I think it's just always worth remembering that the pace that you offer the spoon, how you offer the spoon, can really affect how that meal is taken and whether they're enjoying it. And at the end of the day, every meal or snack should be a pleasant experience, an enjoyable experience for everybody. So we'll just move on. So gagging. Now, gagging is normal. Gagging is actually the body's, I guess, defense, very protective of the airway. And it's literally to try and stop any choking from happening. Now, babies are born with the gag reflex quite far forward in their mouth, and over time it moves further back. And we may all gag if you with your toothbrush stick it too far back in your mouth or something, that might force you to gag. But again, what happens is, and what we want is for that gag reflex to reduce as the baby or the young person gets older. Now, what normally happens with gagging is that it's quite obvious. Often the tongue might come out, the eyes might widen. There's sometimes a bit of a noise, but afterwards they're pretty calm. Breathing is normal. There shouldn't be any wet or gurgly or crackly sounds. And again, the gagging reflex should diminish as the weaning journey continues. But some children do have a very hypersensitive gag reflex, and especially if they've got other sensitivities. For some children, it can lead to vomiting, But again, if you're noticing that it's incredibly sensitive, then you might want to sort of suggest a referral to occupational therapy or OT for more desensitization advice. But what's really key is that when you see it happening, is to just sort of reassure, maybe stroke them, pat them, just say, "Oh dear, oopsie, that was too big, or that was too far back. Here we go, smaller, chew, chew, chew," and just reassure, reassure, reassure. Now, this is one side of things. So gagging is one thing. And then I'm sorry, I don't think you can see maybe the top of this slide, but we've got choking is the other side of things. And that is obviously a lot more serious. So it may start with coughing and spluttering, and that is another good sign, because that means that they are trying to protect their airway. Now, partial choking or full choking is when the airway is becoming blocked, and that might happen with food, but can happen with other bits and pieces that they might get their hands on. So a small toy, pieces of tissue, a piece of cloth, something like that. What usually happens is that it's quite quiet, if not silent, and they can look incredibly panicked and really quite distressed. And certainly a full choking episode would be silent and really quite scary. I really hope none of you have had to experience that. What I recommend, if you are really anxious about your weaning journey, or that this has happened to you, or you're worried that it might happen, is doing a mini first aid course. They can really reassure of knowing what to do. I think instinctively, you probably would know what to do, and that is you just pick up your child if they're small enough, and you would pat them on the back. If you're really, really worried that their breathing really is compromised, then you call 999. And what I always recommend is, with your mobile phone, you keep patting them on the back. You put your mobile phone on speakerphone whilst you're calling 999, so that you can keep doing what you need to be doing to hopefully help your little one, but also simultaneously calling the emergency services. So if you're familiar already with what to do in a choking event, well done. There is a really good website on the NHS, and it's literally called NHS Help with Choking, if you're wanting to have a look. But again, I'm hoping none of you will actually need to use that. So this slide relates to IDDSI. It's a relatively new framework that came in about, 2017. So goodness me, that is about 8 years ago, isn't it? So not that new, but it stands for the International Dysphagia Diet Standardization Initiative, which is incredibly long and complicated. And basically, it relates to how speech and language therapists and other people in medical teams refer to the different consistencies of food. And somebody very clever basically decided that they could number them. So I want you to have a look at these two triangles. The one on the left is for foods, and the one on the right is for drinks. And it starts from 0 and goes up to 4 for liquids and drinks. But equally, some very, very thick drinks could look like a puree or a yogurt. So that's why 3 and 4 are both identified as being drinks, but also a food. And then after number 4, we've got 5, 6, and 7, and we're thinking sort of minced and moist, which would be a very, very, very soft, very, very small cut vegetables, very, very small bits of, say, mince, and think of a cottage or shepherd's pie, something like that. Soft would be maybe really soft flaked fish, something like that. And then regular is really sort of any diet, any food that is a bit firmer and you might need to bite or chew. Just by Googling IDDSI, so IDDSI framework, or IDDSI, and I think you could put in, I think it says patient leaflets or something like that. It comes up with every single level, so from 0 to 7, as well as foods to avoid. And I'm just showing, I share this slide just in case you've come across this term from your speech and language therapist and you haven't been shown what it relates to. So again, following on from IDDSI, what we used to call the different consistencies was really very, very confusing. And the team that devised the IDDSI levels worked out that actually the easiest way to confirm what the consistency and the preferred consistency that we want to give a child is using what we call, one is called the IDDSI syringe flow test. And then there is also, for certainly sort of IDDSI level 4, to check that it's IDDSI level 4 rather, we call the fork drip or spoon tilt test. So I'll start with that one. So if you are a bit worried that your little one has got a difficulty managing thin sauces, thin liquids, that sort of thing, then if you were to scoop up, say, a yogurt, a good petit filou, that's probably an IDDSI level 4, because if you were to scoop it up with a fork, it wouldn't drip through the fork. If it does drip through a fork, then it's less than an IDDSI 4. It's going to be a 3 or possibly a 2. With the syringe flow test, I want you to imagine filling up a 10 ml syringe with a liquid. And let's start with water. If we filled it up with 10 mils of just water and then let it just take 10 seconds to flow out, all of it, if it's just water, would flow out within that 10 seconds. And that's telling me that that water is thin and it's an IDDSI level 0. Compare that now to a good old-fashioned chocolate milkshake from McDonald's, which is super duper thick. Again, fill that syringe up with 10 mils, leave it to drip out over 10 seconds. I suspect that there would still be about 9 or 10 mils left in that syringe because it's just so thick, it's not going to drip out. So that would tell me that that's an IDDSI level 3 or level 4. And so we often use these descriptions and this test to assess which drink, which type of fluid, which consistency of fluid rather, is going to be safest for your little one to be able to drink. So this is just a few more bits and pieces on the fork drip test, the spoon tilt test. Another one is when you're assessing perhaps the firmness of some foods, and a really simple one is to press with a fork using the thumb on the edge of a fork. And if you have to press really hard and your finger starts blanching, then it must be pretty firm, and that might be too firm for your little one. Again, I would suggest that you have a look at the IDDSI.org and the food testing methods for more information, or indeed ask your speech and language therapist to go through and show you the different testing methods. So what are the other factors for swallow safety that we sort of have to keep an eye on? And positioning of the child as well as yourself. So if your little one happens to be on your lap, that's fine, but just make sure that you really support them with your arm around them so that they can sit up and that they're quite close to you. If they're in a high chair, make sure that you're either opposite them or at a 90-degree angle, preferably when they're seated in a chair. We really want that sort of head and the trunk as well as the feet supported so that they're not sort of flapping around. It just gives them more stability. And then have a think about the noise, the visuals, the whole environment. Are they really, really distracted? The noise level is really important because we want you to be able to hear them in case that wet, crackly voice starts happening, or perhaps they do a little bit of a throat clear, which could suggest that food or drink is going down the wrong way. So try and have noise levels to a minimum. What type of utensils are you using? Now, absolutely, when you're starting out, brilliant to start with finger food. We want them to get messy. We want them to get sticky. Try to only wipe at the end of a meal. Easier said than done sometimes if it's super duper messy. But equally, do give them utensils, but just make sure, is it the right size? Is it the right shape for your little one? We don't want them too big. We don't want them too deep. The bowl of the spoon, the flatter, the better, certainly to start off with. So just have a think about that. Now I've put if stressed. So your adrenaline levels are going to be high if you're stressed, as well as your little ones if they're stressed. And we just know that any stress for your little one can actually affect their appetite. So we want it to be a fairly calm environment as much as possible. And again, it's sort of all linked back to the powerhouse, which is the brain, because when we're stressed and that adrenaline level goes up, it turns off that appetite. So we want everybody to try and be as calm as possible. So the summary is really about, the positioning, the utensils, but also the pace. And that really depends on the child. We know that too slow can be really, really frustrating, but it might be that you have to go super duper slow in order to keep your child safe. So what you can do is maybe give them an empty spoon to play with. You can maybe do a few toys on the table if you're needing to distract them. But the really key thing is not to go too fast, because that's when everything can go a little bit awry and they get more uncoordinated. And then it's volume, quantity. It's making sure that it's not too large on the spoon, because too big a piece in the mouth, they're not going to manage it. It might all end up outside of the mouth anyway. And smaller amounts do need more precise chewing. Now, for some children, it might be too small that they're not getting the feedback. So it's really important just to sort of monitor how your little one is getting on. As I said before, the wiping, try not to wipe throughout the meal. If it's getting in their eyes, then by all means, or they're getting really distressed, then absolutely. But try giving them a dry cloth and encouraging them to wipe themselves, because ultimately what we want at the end of the day is for them to become independent. So even from, the word go, when you start off that weaning journey from about 6 months, at the end of the meal, give them a dry cloth and just say, wipe, wipe, wipe. And they might not be able to do it, but you can do some hand over hand and just sort of support them with that. And then how do we talk? Well, what we want to do with that communication is really sort of follow their cues, make sure that we're sort of talking specific, so making language really, really concrete. So talking about the food and saying, oh, look, yum, yum, carrot, and showing them that sort of thing. And then, as I've talked about already, the noise levels, the lighting levels of the environment, have a think about how it feels to be there. So who else might be involved? In an ideal world, I would like to think, and again, this is specifically for children with perhaps eating and drinking difficulties, your health visitor, there might be a specialist health visitor, there might be a CNN, so we call them community nursery nurse, or a CCN, which is a children's community nurse, dietitian, pediatrician, occupational therapist if there's some fine motor or sensory issues going on, physiotherapists, they often work very much linked with the OT for positioning and maybe equipment, so seating. Occasionally, if you're really lucky, there'll be a psychologist as part of the team. We don't have one specifically where I work, but I can sometimes refer to them. And that's for certainly behavioural issues. And then obviously we've got you guys are very, very key as the parents, but also the wider network of extended family, but also teachers, TAs, nursery staff, parent helpers, that sort of thing. So everybody that may be part of your child's day-to-day life is key when it comes to the eating and drinking. So that's the end of the presentation. I